The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar entitled Morbidity Challenges and Treatment Advances for Hemophilia Carriers, focus on Factor IX and Factor VIII and management of these disorders. My name is Dr. Roshni Kulkarni, and I'm a founding board member of the Foundation for Women and Girls with Blood Disorders, and I will be moderating today's webinar. Next slide. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally treated and managed at every stage of life. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide. Today's presenter is Dr. Robert Cydonia. He's an excellent presenter. He's the Associate Director of Hemostasis and Thrombosis and an Assistant Professor of Pediatrics at the Aflac Cancer and Blood Disorder Centers at Emory. Next slide. Next slide. The Activity Medical Director for today's webinar is Dr. Andra James. The planning committee for today's presentation include Dr. Barbara Conkle from University of Washington, Dr. Kenneth Mann, formerly Emeritus Professor at the University of Vermont, James Munn from the University of Michigan, Dr. Jennifer Dietrich from Baylor College of Medicine in Houston, Dr. Evelyn Lockhart from the University of New Mexico School of Medicine, and me. Next slide. In accordance with the Creighton University Health Sciences Continuing Education Policy, the Faculty and Planning Committee for today's webinar have disclosed any significant financial interest or other relationships of interest relative to the topics that will be discussed during this program. Such disclosure allow you to better evaluate the objectivity of the information presented in the webinar. Next slide. To ensure the best sound quality during the webinar, all attendees will be muted. However, all attendees will have the opportunity to participate in a question and answer session with the instructions at the end of the webinar. You can submit your questions during or after the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen, and we will address them during the Q&A session at the end of today's presentation. We gladly welcome your input. Next slide. This learning activity is offered through the Creighton University Health Sciences Continuing Education Program, which has been accredited for offering one AMA PRA Category 1 credit for physicians and one contact hour for nursing professionals. Next slide. So here is a poll. Before we get started, we would like to quickly poll our audiences to see how many people are watching the webinars with you today. Please take a moment to tell us, whether you're watching alone or whether you're watching with a group, and enter your response using your keyboard. Okay, I hope you guys have entered your response. Thank you. And the next slide. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we will record and archive this webinar on our website, fwgbd.org. I would now like to introduce our speaker, Dr. Robert Cydonia. So Robert, take it away from here.
Thank you, Roshni, and thank you to the audience, and thank you to FWGBD for allowing me to talk about my favorite topic. We all know that Roshni could give this talk in her sleep, and I'm grateful for the opportunity to give this talk. So as with most of my presentations, I like to start off with a case because what we're trying to do is we're trying to illustrate the lifespan of a patient that's a hemophilia A or B carrier. So the first case is a 5-year-old female who was seen to evaluate for her recurrent nosebleeds and frequent bruising. Previous testing showed a normal APTT of 38 seconds, and remember that the ranges differ from institution to institution. Her factor IX activity was 45%. History showed that she has no history of surgeries or procedures. She does have a maternal grandfather with severe hemophilia B. And at this time, they wanted to inquire about genetic testing and wanted to have a discussion about the bleeding risk. So the diagnosis of a hemophilia carrier, as one would expect, it should be a straightforward process, but as time has shown in this disorder, it's been a very complex issue. So we know that carrier testing and demonstration of the baseline factor activity is probably the most important thing. It's important to offer genetic testing in the context of having appropriate counseling with a genetic counselor. We know that there is still controversy about the timing of the testing. What isn't controversial is that we should be offering genetic testing prior to pregnancy, and it should be strongly considered prior to menstruation or the first period, and definitely considered prior to surgery. I've summarized the different governing bodies throughout the world, and most of them say the same thing. They probably consult with each other, but we know that it makes sense to do it before pregnancy. We all have plenty of patients in which we are having a discussion as the baby is being birthed. It's important to offer PGD or pre-implantation genetic diagnosis. Some places offer fetal sex determination prior to the ultrasound. And all these things should be a discussion that has in the setting of family planning. Just to sort of take a step back to look at the global impact, this was a nice presentation done by Mark Skinner years ago. Just for people to understand sort of the prevalence, when you're looking at the number of patients with von Willebrand disease, in contrast, there are approximately 6.9 million people in the world estimated. That doesn't mean that this doesn't include the patients that are identified. We know that there are probably upwards of 500,000 hemophilia A and B patients that are males. And if you look based on different registries in the first world, you'll see that there are at least 360,000 what we call symptomatic carriers or carriers with some deficiency. So that's a large population of patients. And I feel like we should probably do a better job of addressing the issues that are important to them. To get a little bit of a local flavor, the American Thrombosis and Hemostasis Network collects surveillance data. They've essentially taken over the surveillance projects from the CDC and work with them in collaboration as part of the CDC Community Counts. This is the most recent data pull. As you can see, there are a total of 569 women that are hemophilia A carriers with and without deficiency. And you can see the most common group, as expected, would be mild deficiency, and we'll talk about why that is so. But most importantly, you can see that there are quite a number of women that are enrolled in the data set, and this is even prior to My Life Our Future, that are felt that they have a bleeding tendency enough to want to enroll in the Athens data set. On the hemophilia B side, as expected, there are significantly less number of patients as there are in males. The predominance is patients with mild deficiency. A good chunk of these patients have enrolled in the My Life Our Future project, and there should be some important data that comes out about them in a project that'll be led by Jill Johnson. I use this sort of topic, and this is something I stole from Roshni, the carrier confusion. I have a lot of one-liners that I'm going to use from Roshni. She's really good at those kind of things. So when we talk about hemophilia carriers, it's a difficult concept. So we know that there's a wide distribution of the levels. The mean is approximately 50%, but there are carriers that have levels as high as 100% and higher, and those that have levels as low as less than 1%. We know the classification continues to be controversial. This is something that Roshni and I are going to address as part of an ISTH subcommittee, and hopefully publish a short manuscript detailing why we feel that we should be using the male severity system when we're talking about levels less than 50%. We know it becomes more controversial when you talk about levels greater than 40 or greater than 50%. I feel like it is appropriate to use the term symptomatic carrier when we're talking about a carrier that have levels in what's traditionally known as the normal hemostatic range. We know that the bleeding tendency extends as high as 60 to 70%, and we'll talk about that in subsequent slides. Part of the issue was that the old billing system, or the ICD-9, did not allow us to bill appropriately for these patients, and we all know if you can't bill for them, you can't treat them. And it's important that we acknowledge that there are new billing codes, and we have to be careful we're not using genetic codes because those don't allow us to get the proper services. So a little bit brief on hemophilia inheritance. This was a nice handout that was produced by Indiana. And as you can see here, the striped woman is the mother who is a carrier. And you can see if she has engages with a male without hemophilia, there's a 50-50 chance that the girls will be carriers and a 50-50 chance that the males will be affected. And that happens with each child. And sometimes this is a difficult concept for providers and carriers to understand. And then contrarily, if the male is affected, none of the male sons will be affected, but all of the daughters will be carriers. And I reemphasize this because we still have males that bring in their daughters and inquire about genetic testing in our clinic. And I feel like that's a failure on our part of not really hammering this point home. This is a slide courtesy of Dr. Kulkarni. One of the concepts that's difficult to understand is this lionization or the lion hypothesis. We know that one of the X chromosomes has to inactivate, forming a bar body. We feel like this is a random process. So on average, if a carrier has one affected X chromosome and another one is not, on average, the level should be somewhere between 40 to 60%. But as people on this webinar know, there are quite a number of women that have levels even as low as 1%, and then they also have affected other females with levels that are below 50%. And we've had a few patients with Turner syndrome, which they have an exo genotype and express hemophilia, and one of those actually developed an inhibitor. And then we feel like there are other mechanisms that are controlling this that we haven't learned about this. So this is really important. We don't know if this changes over time, and we're currently working on inactivation assays to further understand this with collaboration with the CDC. Most importantly, though, is that a third of these women that carry the gene have some bleeding symptoms. It's also important to acknowledge that some women have absolutely no bleeding symptoms. But we know that this happens also in hemophilia and with other mild bleeding disorders. And it's important to figure out how we can better predict this. This is a nice, from a 2015 genetic book that Casper had written, and this slide is a courtesy of Dr. Konkel. But it demonstrates in a small study of the overlap of the patients with levels in the red. Those are the carriers. They generally had lower levels, but you see there were carriers with levels as high as 110%, and some with levels as low as 10%. And that overlaps with the normal women who may have levels as low as 50%. So that makes it a little bit difficult and a foreign concept for some providers, particularly if they're in the emergency room. I can't belabor the point about genetic counseling. That's really important. In this day and age of sort of penny pinching and limited 340B money, genetic counselors, unfortunately, have been the first on their way out in the comprehensive clinic model. We need to make sure that we have access to good genetic counselors. We have a program here at Emory in which we have students that rotate through our program, which we feel is very important because if we're at least not going to employ them, we at least want to make sure they're well trained. It's really important that when we're discussing the results, that we have a counselor that can engage them and make sure they truly understand the implications of the results, particularly for those that are not adult age. It's important that this is different in different parts of the country. It's different when you're talking to the Amish population versus talking to an urban population to a rural population. And we know that there are cultural differences as well. And this sort of thing is highlighted in the WFH symptomatic carriers handout. And it's important to have another member to provide emotional and psychological support. And it also allows them to help connect these patients to other patients as well as patient advocacy groups. So going back to that patient, that 5-year-old, we ultimately determined that they were a genetically verified carrier as would expected. And then we wanted to discuss further what kind of bleeding symptoms are expected. When I talk to a lot of males, particularly older males with hemophilia, they're always quite astonished when I give a talk about hemophilia carriers and their bleeding tendency, and they all feel like maybe they missed something and they didn't acknowledge it. Obviously, it's a different time than it was in the 80s and 90s, and I feel like there's opportunities now to make sure we focus on women in our HTCs and make sure that they're a welcome part of the comprehensive clinic model. So how do the carriers present? Well, they can present with a lot of bleeding symptoms. What I'm not showing on here is when we looked at the difference between a hemophilia carrier and a patient with type 1 von Willebrand disease, mucosal bleeding is common, but it's much more common in those that have type 1 von Willebrand disease. You'll see much more mucosal bleeding, nosebleeds, and GI bleeding, a little bit more prevalent than in the hemophilia carrier population. And more importantly, you see more muscle bleeds, joint bleeds, and other bleeding types in the carriers compared to the type 1 von Willebrand patients. So it's important to acknowledge that this is a distinctly different population. It is not, you can't just completely attribute the bleeding symptoms to von Willebrand disease, assuming that they have similar levels. When you look at probably the best paper that's come out on this was published in Blood in 2006, and it was followed by an editorial by Lou Alador. When they compared carriers and non-carriers in a postal survey, as you can see there on the right column, they had hemophilia A and B carriers, and this is before genetic testing was done at the site. This was done in Europe, and you can see the range was as low as 5% and as high as 219%. We know that carriers bleed when they have lower levels, but what's so interesting to me was that carriers with levels of 40 to 60% were at additional risk for bleeding, as evidenced in this chart. So if you look at in the orange boxes, carriers were more likely to bleed with small wounds compared to non-carriers. They were more likely to have bleeding 3 hours later, more likely to require treatment after a dental extraction, and they were more likely to have prolonged bleeding following surgery. So this study was probably the first one that definitively showed that there is some bleeding tendency. Fast forward a few years later, and there were subsequent studies that also further supported this notion. In 2011, Meisbach showed in a small study that there seemed to be an increasing bleeding phenotype if you look at the mutations. And for a while, they felt like if you had a patient that carried a severe mutation, you were more likely to have bleeding symptoms in a carrier compared to a woman that carried a mild mutation. They demonstrated in this small study that there was some increase in bleeding phenotype based on the mutation type. We have done this study multiple times and have not shown this or reproduced this. I don't feel that it probably is a true finding in a larger study, and maybe it has to do with the outcome that we're using. Another notion is that carriers that have different mutation types will have different levels. That was disputed in the 2010 manuscript, and we have not seen that internally as well, either here at Vanderbilt or at Emory University. When you look at the hemophilia B patients, you can see this nice dotogram here, and on the left side, you'll see the factor IX levels in the non-carriers and carriers, and you can see the baseline levels close to 90 in the non-carriers and close to 50% in the carriers. If you separated them out by severity, you can see in the nice little dotograms, it looks like a little tree and some other pictures, you'll see that there really was no difference in the levels based on the mutation type. The interesting finding is that once you got above 75% in a female, you became very unlikely to be a carrier. So that could be a reasonable first pass, sort of a poor man's ability to look for carrier status when you don't have the ability to do the testing right away. Obviously, you would follow that up with levels and with genetic testing. A study that I conducted with Dr. Allison Porosky, now Allison Wheeler, while I was at Vanderbilt, as you can see here, we did a cross-sectional study in which we demonstrated fairly definitively that carriers, hemophilia A carriers, have an increased bleeding phenotype. Everywhere you see an asterisk shows you where there was increased bleeding. Most notably, there was bleeding symptoms seen in the joint, and we got prevalence levels of about 18% compared to other studies in which they got similar results and similar as the plug study. And most importantly, I think here is that heavy menstrual bleeding, as you can see in this orange bar, was very common in normal women. This is a common problem, but it is obviously more prevalent in those that are hemophilia carriers. And a lot of those women minimize their symptoms and feel like it's something that's just part of being a carrier, so they don't often report it. If you look at additional other bleeding symptoms, there continues to show a bleeding tendency, maybe not in every bleeding symptom, but in quite a number of bleeding symptoms. When you culminate that into a bleeding score, something we call the pictorial bleeding assessment chart, which is a semi-quantitative assessment of menstrual bleeding, it showed that there was clearly an increase in the bleeding chart. And just for reference, anything over 150 is considered heavy menstrual bleeding. So these women, we actually worked up all these women for bleeding and clotting disorders and did not find any that had von Willebrand disease, platelet dysfunction. We excluded one patient because she had factor V Leiden mutation. And a similar workup was done in the carriers as well. When you quantify this using the old Italian bleeding questionnaire, the MCMD1 questionnaire, there showed that there is definitely an increased bleeding score. This was further corroborated by Paula James' group out of Canada that demonstrated very similar discrepancy in bleeding based on more recently validated bleeding scores that she created. When you look at the Hemophilia B population, oftentimes I get asked, why haven't you done as much research in the Hemophilia B carrier population? Well, numbers are a big part of it. We have currently 50 patients with Hemophilia B in our pediatric side. And so there are just not as many patients, and we have over 280 Hemophilia A patients. So it's more difficult, so we rely on some of our colleagues that have a higher population. But when you look at across the board, the bleeding tendency is the same. There doesn't seem to be any worse bleeding symptoms, possibly more bleeding in postpartum hemorrhage. And remember, factor IX levels don't increase with stress response, which may explain why there's some increased bleeding with surgical procedures. One of the big focus of the initial study that I did was on joints. We were able to obtain the CDC Universal Data Collection Project data, and we analyzed the over 450 women. There were actually a lot more in that data set. We had to eliminate patients based on the fact that we did not know because you had to write in whether they are Hemophilia A or B carrier. But when we looked at the joint range of motion recorded on there, we actually had a reference to a normal study of women that don't have a bleeding disorder. And what we showed was, in most circumstances, carriers with normal, mild, moderate, and severe deficiency showed a reduction in joint range of motion. This would indicate, as a surrogate, that there is some bleeding tendency going on in the joints and possibly microbleeding that may lead to some joint reduction in the range of motion. We are further exploring this with quality of life and show that there was a reduction in quality of life in carriers versus normal women, and we're going to be further getting more information about whether that extends to functional status. So moving on to the second case, let's talk about an 8-year-old carrier who needed to have her tonsils removed. Again, these are cases that I've encountered since I've been a provider here previously at Vanderbilt, now at Emory. So this grandfather had severe hemophilia B. The mother's an obligate hemophilia carrier, and this carries levels as expected. Level was somewhere between 45 to 50%. I actually did not see this patient. One of my colleagues did. When you talk about management of bleeding, it can be quite controversial, particularly if you have borderline levels. It's very simple if your level is 10%. We all know what to do with that. But it's much more difficult because we want to make sure we don't cause harm. Most guidance says that if you have levels of less than 50 to 60, you should consider using factor replacement or possibly DDAVP in the hemophilia A carriers. And for those with levels above 50 to 60%, great caution should be used. Obviously, we don't want to cause elevation of the levels that induce a clot, but you should heavily rely on oral, IV, and topical antifibrinolytics, typically aminocaproic acid and Lystada. This is a nice chart based on a paper by Mauser Benschatten in 2008, and it illustrates sort of what we mentioned here. And if you go to this chart in the hemophilia B carrier with levels of greater than 30% but less than 60%, a single dose of factor replacement is recommended. And obviously, if the level is lower, you would consider using a higher dose of factor. And contrarily, on the hemophilia A side, you have the option of using desmopressin high dose or DDAVP in its multiple forms of sub-Q, IV, and intranasal. So going back to the case, no intervention was actually done on this patient, and re-presented back on day 7 with severe anemia. The patient started coughing and then started coughing up buckets of blood, had significant post-tonsillectomy hemorrhage, had to be admitted to the ICU and intubated, sorry, excuse me, and had to receive 2 doses of recombinant factor IX and a 10-day course of antifibrinolytic. When she came in, her levels were in the 30 to 40% range, which makes sense that she probably consumed some of the factor and some of it was used in the tissue. And this illustrates the issues with the lack of stress response with the Hemophilia B carriers. And in hindsight, this patient probably should have received at least Amicar and possibly 1 single dose of a recombinant or plasma-derived factor IX product. So moving up in the age group, now we have a 13-year-old who is an obligate Hemophilia A carrier, who has heavy periods, is with the typical reason that I'm seeing these patients in the clinic. This patient actually presents to the emergency room. She had dizziness, had a near syncopal episode. The ED resident calls us, asks us what to do. We get a little bit of information. We know that her period started at age 11 and they've been irregular subsequently right out the bat, and then they've just gotten progressively worse. We know this is a typical pattern. Either they start off normal or they progressively get more irregular and worse, and then what happens is they have this horrible anovulatory cycle of bleeding. So I think it's important to talk about the definition of heavy menstrual bleeding. The clinical one is more than 7 days of menstrual bleeding. That correlates with over 80 mils of blood. Probably the best way to do this is to predict it is if they are reporting that they're passing clots greater than the size of a grape. I know we have an international audience. They don't always use inches outside the US. If they've had a history of iron deficiency anemia and don't have GI bleeding, and if they're changing their pad or tampon every hour or so, it's important to get that because those are highly predictive of heavy menstrual bleeding. We have some of these old-fashioned charts that were created many years ago. We've attempted to update this, and there's actually an app that you can download for free called the Sisterhood app. Recently, Maggie Ragney had a student that demonstrated that the people involved in utilizing this felt like it was as good or better than the paper charts and felt like they would use it afterwards. We know that a score of greater than 150 has good sensitivity and specificity. And for now, it's really one of the better things that we have because it allows you to email this to your provider and keep a better track than using one of those older calendars. Talking about adolescent bleeding, we always have to talk about anovulatory bleeding. We know that there are cycles in which ovulation doesn't occur in adolescent girls. So thus, you don't get a corpus luteum to secrete progestin. The ovarian estrogen becomes unopposed. And then the endometrium stays in what's called the proliferative phase and doesn't thin out. And what happens is you don't get regular full shedding. And over many, many cycles, you get incomplete shedding, and then the patient reports 30 to 40 days of menstrual bleeding, which often lands them in the emergency room. There are lots of options in reducing heavy menstrual bleeding, and they don't all include IV medications or factor products. We know that in the proper hands, hormonal control is a reasonable option, at least should be considered. There are many options, including in patch, ring, and pill and IV form. Combined oral contraceptives, progestins. We offer IUDs as an option, the most common being Mirena and Skyla. And then for patients outside of this, we're not talking about hemophilia carriers, we have often had to use GnRH analogs, particularly in patients, adolescent girls that come in with a new diagnosis of aplastic anemia or leukemia. So there are many ways to manage this, and really it starts with a simple question. Are you considering pregnancy soon? I see pediatric patients, so the answer is always no. We know that there are good options, including the IUD. I offer, and we'll discuss in subsequent slides, combined oral contraceptives and progestins as options. We don't like to make those decisions for patients. There was a recent New York Times article discussing that physicians may be preventing patients from getting things like endometrial ablation and hysterectomy. That's an ongoing discussion. I really would like families to think really hard about whether endometrial ablation is an appropriate option, because you're talking about fertility loss over the next subsequent decade. And we want to make sure that they have informed decisions when they're in their early 20s. We know when they're thinking about getting pregnant, we can think about other options like antifibrinolytics. Lystada has been studied and shown to be efficacious in this population, as well as Amicar. Factor concentrate is something that we're studying as a pilot study. This is a study that we are conducting at Emory University, and hopefully we'll have our first patient in the next 2 weeks. DDAVP can be considered if you are a hemophilia A carrier, and we're not talking about this, but also in von Willebrand patients. So what has been reported? If you look at the Female Universal Data Collection Project, which attempted to gather more data on women, and this happened immediately when the UDC closed. And so some of this will be applied in the upcoming Athens dataset registry questions. But oral contraceptives was by far the most commonly used form of menstrual bleeding reduction. And you can see following that included DDAVP and antifibrinolytics. Again, in the Athens dataset, which is a much larger number, desmopressin, Amicar, Lystada, or tranexamic acid are common. And then factor concentrates move further down the list and mostly are in those that have von Willebrand disease. So we have very little data on how it works in hemophilia A and B carriers other than anecdotes. We know that combined oral contraceptives are good. There's some contraindications and relative contraindications if they have migraine headaches with aura. In general, if the patient has headaches, this is probably not a good option because they probably will get worse. If they have any thrombosis risk factors, it would probably be advisable not to use this. The best options and the ones that we use here are Levora, low egestrol, and low estrogen, and the main reason is they're covered by all insurance, at least at this time. We want to consider ones with anti-androgenic progestins if acne is an issue. We've had some good results with Seasonal or Jalessa as an option. These tend to work well in obese patients and those with really irregular bleeding and those that also have PCOS, and also in those that have ovarian cysts because these patients are at risk for hemorrhagic ovarian cysts. One common strategy listed there is to have a taper. This is the taper that we use here. We often make people skip the placebo pills in the first couple of months, and then we transition to either Seasonal, Jalessa, or which is the generic version of that, or have a period every 2 to 3 months just to ensure that there's some shedding and no irregular bleeding in between. Another common approach, excuse me, is agestin or norethindrone in the high dose. So this is not the micronor. This is the progestin-only pill. For girls that are less than 50 kilos, you probably can get away with a 5 milligram tablet alone. Most patients have secondary amenorrhea in the subsequent 4 to 8 weeks. I've noticed as a side effect, emotional lability and fatigue are the most common reasons, at least here. It's really important that you tell people that this is not a very good form of birth control. It's somewhere in the 90% range, and that's obviously not good enough if you're using it for birth control. We have over 15 patients here that have bleeding disorders that have not had periods over 12 months, so we know that it works in adolescent girls, but there are some patients in which it doesn't work. Obviously, this is a way, I feel like visually, this is how a lot of female patients report their periods are like to me. I don't have a uterus, so I don't know. But obviously, this is sort of how a lot of these teenage girls tell me that they feel like it's so much better. They're more in tune with their periods, and they don't feel like it's sort of an angry visitor that comes once a week. We had some patient refer it to as Shark Week, which I thought was a very vivid description of their periods and really conveyed the point of heavy menstrual bleeding. So moving on into the sort of middle age, and we're talking about a 30-year-old now that's a hemophilia A carrier, and she wants to talk to you about getting pregnant. She wants to do family planning. To be honest, I wish there were a lot more patients like this. I feel like this is actually a minority. We often are hearing about these patients from genetic counselors in the 3rd trimester of a patient, and I would love to see more of these patients come to us and for these further discussions. She was diagnosed as type 1 von Willebrand disease previously. I think that's a common label that a lot of carriers have. I would seriously go back and consider whether this is a true label, because a lot of patients did not understand the concept of lionization and felt like a lot of women have von Willebrand disease, particularly in those that have blood type O, which may have a lower or sort of low normal von Willebrand factor. In this patient, there were no previous surgeries, some oozing with dental extraction, some oral bleeding, easy bruising, and then she needed some combined oral contraceptive for her heavy menstrual bleeding. This is a nice chart demonstrating what happens to factor during pregnancy. We know that factor VIII goes up, including von Willebrand factor. It's important to know that factor VIII and von Willebrand factor tend to be elevated at birth as well. And then the vitamin K dependent factors are low in the infants. But again, we're talking about pregnancy. Factor IX level does not go up significantly. It may move up 5% or so, but do not expect any major increase. And know that there are other coagulation changes that tend to favor thrombotic environment or prothrombotic environment to make sure that the woman doesn't have significant postpartum hemorrhage, and probably an evolutionary benefit to prevent death from postpartum hemorrhage. A great chart that I love to use in talks. As you can see here in the non-pregnant patients, their baseline factor VIII levels, when we're talking about hemophilia carriers, starts off at 46, and on average by the third trimester, they've increased approximately 2 to 3-fold up to 120. Factor IX patients may go up slightly, but there's no statistical increase, and that's evident by the dotted lines here. So it's really important that you identify those carriers that have low levels, because they may not get levels that are high enough for hemostasis. And remember, a normal women's level will go above 200% on average, oftentimes even higher. And so there probably is some evolutionary benefit of having extremely high factor VIII levels at the time of delivery. So let's talk about delivery planning. Those are fairly straightforward. We should avoid fetal scalp electrodes in the neonate. Most people don't realize that these are tiny little screws that are screwed into the skin of the infant to assist with monitoring, which is very critical. Obviously, the biggest thing is to avoid forceps and vacuum extraction. It's important to avoid the vacuum extraction during a C-section as well. The recommendations are to consider C-section if they're at high risk, particularly for severe hemophilia. There's no strong recommendations that a C-section should be done. And there is a theoretical risk of lower risk of intracranial hemorrhage if delivered by planned C-section. Unfortunately, it's not often known whether the child is going to have hemophilia, and so there's a lot of cultural discussions about how many C-sections would be considered acceptable, particularly in patients that don't end up having a child with hemophilia. We obviously want to defer circumcision. We want to get that cord and test for factor VIII and factor IX, and also a PTT, because you can get an idea if the patient is going to have hemophilia. We make sure we don't rely on the exact level, that we rely on the history, but if it's low, we know that the patient is affected. We know that it's important to keep the levels above 50%, which is typically done naturally for vaginal delivery, and maybe need to be monitored as C-sections that may need to be maintained higher for 5 to 7 days. And we don't really have good data on how quickly it drops. We have good data on von Willebrand disease from Andy James' great paper in those patients, but not so much in the hemophilia A and B carriers. We know that the postpartum hemorrhage rate varies. It depends on the country. It depends on the definition. The Dutch group reports a higher rate, but they have a fairly liberal definition of what's considered postpartum hemorrhage. Probably it's closer to somewhere between 20 to 30%. And there are a lot of other measures that can be done to lower this rate even more. But without good prospective data, we have to rely on these retrospective studies to really decide what the true rate is. Let's talk about the fourth case, a 30-year-old that is pregnant in her third trimester. She decided to go ahead and get genetic testing. Thankfully, we were able to get it done. She has the classic severe mutation that's seen in 45% of males with severe hemophilia. Her levels mimicked exactly what was seen in the article that I just illustrated, that she started off with 45% and ended up with 120%. She opted to deliver vaginally. For no issues, we know that we would have rapidly converted to a C-section if there was any issues in the later stages of delivery, and we would not have pursued that as soon as there were any issues. There were no antifibrinolytics warranted, and she did not get factor. So I would be remiss to talk about the challenges with regards to carriers without talking about the wonderful projects that are ongoing throughout the country. If you need a primer on how to develop a multidisciplinary clinic, one, you can reach out to Carrie, but also you can talk to Aisha Zaya, who's written a nice primer on how to develop a multidisciplinary young women's bleeding disorder program. And further programs have been developed over the last few years, including the one that we created at Emory, and a great program that they have in Portland as well, led by Dr. Haley. So this is a great manuscript. I would employ everybody to read this manuscript. Again, I think it's really important that we talk about the role of the Hemophilia Treatment Center. There are some providers that have not gotten on the bandwagon, the women's bandwagon. I think most of us are on it, and we know we're moving forward. So, so either they get on or they get left behind. I think it's really important that we strongly consider employing GYNs in our HTC clinic. We have them at our clinic. I think they've been a wonderful addition. We know that if half of the patients that we're seeing in the clinic are women, and most of the women use their GYNs as their primary doctor, it's really important that we engage our GYN colleagues. And I think it really helps us better manage their menstrual bleeding and help manage, particularly when they become old enough to talk about having children. I think it's really important to support development and implementation of women's programs. FWGBD is a leader in this. We want to continue to educate our providers. Obviously, medical resources are limited. They're not finite. They are finite, and we want to make sure we're utilizing those resources efficiently. I really would like to get and hammer the point home about getting prenatal care visits, developing pregnancy and delivery plans. We have handouts here that were created by Dr. Kempton in the past that go through the steps of getting cord blood, and then really coordinating surgeries, co-managing heavy menstrual bleeding, and really trying to prepare what happens when that child is born. Because as we all know, those children are not born in academic settings. They're typically born in private hospitals, which may or may not have any factor and may or may not have experience in managing a patient with possible hemophilia. There are a lot of people that I want to thank, most importantly FWGBD for allowing me to talk today about my favorite topic. Roshni has been like a mother to me and has been a great mentor, including Andy James and Peter Coedes, previous mentors and Michael Devon, and current ones at Pete Lawler. There are a lot of people listed on here. This work that's being done at the CDC, I want to make sure everybody understands there's a lot of work being done behind the scenes at the CDC, also at NHF and HFA. There's concerted efforts improving our surveillance data sets through Athens, and that's being led by Christina Haley, and who has the current DREAM Award. And then, I couldn't thank anybody going to these meetings. It's important to thank all the women and girls with bleeding disorders for bringing this issue up, for hammering that point home. I heard you loud and clear. And I think it's important to take those kind of anecdotes, bring them back, make sure we craft it as a proper research project, and study that in a prospective manner. There's some great resources that I've listed here, great websites on here. And it's important to go to FWGBD. You can look for the HTC resources and what is available in your area. There is an ability to do a bleeding score on the Canadian website, Let's Talk Period. And then you can download the Sisterhood app. If there were issues in the past, we have a newer version that has less glitches. And then I have to end with the last slide. So I have to say that Roshni might have coined this term of Shima Philia. And I think it's a proper term that to use, and I believe that's patent pending, so nobody can go out there and create any T-shirts without paying Roshni residuals. So thank you again for allowing me to talk today and enjoying your lunch. At this time, I'll let Roshni and Carrie take it from here.
Well, thank you very much, Robert. And this was truly an excellent presentation, and I really don't have a patent pending, so anybody can use this. And believe me, FWGBD is pleased to provide this webinar and continuing education credits free of charge. Please feel free to use this so that you can educate other providers and members of your HTC wherever you are, because the idea is to provide education. And help us to continue our strong educational program by answering the evaluation questions and the post-test questions that will be sent to our email shortly at the end of the program, so we can demonstrate our impact to our funding partners. So for participants of this webinar who are interested in receiving continuing education credits, instruction for applying for credit will be emailed to you shortly after this webinar has been completed. And the next slide And so there it is that you will receive a survey. So please fill it out. And what I'd like to do is that we will proceed with the question and answer part of our program. As a reminder, participants may ask questions via the chat box in the GoToWebinar control panel, and questions will be answered in the order it was received. So let me begin. We do have some questions, that we have received. The first one says, I thought aminocaproic acid or Amicar was contraindicated in pregnancy nursing, but you mentioned it as a possibility in those considering pregnancy. Could you further clarify?
So that's a great question. So we're not obviously going to be doing those studies. We know that Amicar is excreted in animal milk. We'll have to discuss whether that's important. When you have a child with hemophilia, it's probably not as important. It's during pregnancy, it's not as much of an issue, but obviously post-pregnancy, when we're talking about breastfeeding, it is something to take into consideration. So I think that's a great point. They're not going to do those studies, but we do think in animal models, they do see this excreted in animal milk. Whether the effects on the infant are unknown, we all know what the effects of Amicar are. It's a fairly low-risk drug, particularly if you are breastfeeding a child with hemophilia. It's unlikely to be a significant issue, particularly because of the high bleeding risk right immediately after birth and then subsequently 6 to 12 months later. So great question. Thank you, Michelle.
Yeah. And so there is a question from Jim Bussell saying, are there any important differences between hemophilia A and B carriers?
So I think that's a great question. When we look at the bleeding tendencies, they seem to be similar. As mentioned before, there possibly is a higher postpartum hemorrhage rate, and that might be because that factor IX doesn't have any significant elevation. There is also the possibility of higher bleeding risk with surgeries, because we know that in patients with von Willebrand disease, hemophilia carriers, and particularly males with mild hemophilia, even the act of stress, particularly if you're attempting to stick the child for the 5th time, we know that factor VIII level is elevated. Ritin Kumar has done nice studies, and Kathleen Fisher, and males with hemophilia is showing that there is a significant stress response, which likely is protective in those with hemophilia A. And so obviously you don't get that benefit in hemophilia B. Part of the problem is the populations that we've been studying. The big studies are done in Amish populations, which is sometimes difficult to compare to English to non-English. And the numbers are just so much smaller. The largest hemophilia B carrier study had 20 patients in it, outside of the Amish population. So it is difficult to tell, but we have to understand the differences with regards to ability to mobilize factor IX, which is not there compared to factor VIII and hemophilia A carriers.
Well, thanks. So here is another very interesting question. Recognition or underappreciation of the disorder seems to be a part of the issue. What are the main clues, or when would you pursue what might be costly testing in a female patient with a bleeding diathesis and perhaps an unremarkable or unavailable adoption, etc. family history? So when the family history is not known, should we check for the factor VIII levels and stop if greater than 75%, or if we think that was physiologically stressful day, we should recheck it again?
So we know that there are patients out there. I think it's pretty few and far between in which we identify a female that's a hemophilia carrier with absolutely no family history or outside of that. We know that the bleeding tendency seems to go up to as high as 60 to 70%. The 75% cutoff was studied specifically in hemophilia B carriers. But I think, when we are typically working up for example, an adolescent or young woman that has bleeding symptoms, we often send evaluation for the most common bleeding disorder, von Willebrand disease. And as part of that panel of laboratory tests, which includes a functional assay, an antigen of von Willebrand factor, and factor VIII. So we know, and a lot of us are keen to looking a little bit closer when the factor VIII level is a little bit closer to normal, either looking for type 2N carrier or heterozygote, or looking for the possibility of a hemophilia carrier status. I don't think we have a really cost-effective strategy outside of genetic testing, unfortunately. They, in the past, in the 1980s and 90s, they tried to come up with these complex mathematical models. And there are some ways of looking to determine whether there's a carrier. Those haven't been validated in prospective studies, so I would be a little bit concerned about relying heavily on that. So unfortunately, there's no really good cost-effective manner. What I think is important is to those patients that continue to have bleeding, you may not see them in your HTC, but keep them in your benign hematology clinic, and think about that when you're eventually sort of continuing to follow, and if the bleeding symptoms continue to persist, you know, then we start to go down more of the costly testing. And obviously, if you have a family member, it's much cheaper. One of the concerning things is that My Life Our Future has officially ended with regards to new patients. And so we will have to address this issue of costly testing and whether insurance is going to pay for it. So very timely question.
Right. So here's another very interesting question. Are there any recommendations for epidurals in the hemophilia carriers?
So I think the most important thing to discuss is that we see these patients, these pregnant patients, early, and we check their levels in the first and third trimester. One of the worst things that you can do is say have a conversation with the anesthesiologist who says, I'm not going to do an epidural while you're in active labor. That's not a conversation I think a lot of women want to have, because they might end up killing that anesthesiologist if they don't get the epidural that they need. But I think it's important to check the levels in the first trimester, and then also check it in the early third trimester. And if there's concern later that's going to happen, if it's going to be a premature delivery, you may want to check it in the second trimester, because most of us would be accepting that if the level in the second trimester is well above 50%, it's highly unlikely, almost nearly impossible for it to be low in the third trimester. You see that sometimes when you're talking about certain types of von Willebrand disease, but that would be unheard of in a hemophilia A carrier. So I think it's important to check those levels during and have those levels available for the anesthesiologist to see, because they're very concerned that they could cause a permanent paralysis if there's an epidural bleed. And this is a concern that they're having more and more of patients on anticoagulants, and you see more and more of this in commercials and discussion. So this is a very heightened issue at the time.
So for older females, do you think an increased ranges should be utilized for recommended interventions?
I mean, that's a great question. Excuse me. It's a great question. You know, there was a wonderful manuscript done by Nowak Goddell and Gilly that was shown at, it focused on von Willebrand disease, and it showed whether there should be an elderly range for von Willebrand disease, because clearly those levels rise with age. And then there's a certain portion of the population that has bleeding below what's considered normal, at least for young adults. And so, you know, we know very little about this. I think it's reasonable to strongly consider things like Amicar in that age, in those, particularly with higher factor levels, particularly if they have a history of bleeding, and then obviously investigate for other bleeding disorders. We have patients that have more than one. I don't think it's extremely common, but I think it is possible. And then not to forget about things like Ehlers-Danlos syndrome or hypermobility syndromes, which may convey some additional bleeding. But unfortunately, we don't have the data. I think with ASCEND, we're hopefully going to be able to track those patients over time and be able to determine whether they have their bleeding tendency changes over time. So a great study that would require a long period of time of analysis, but I think it's something that we should do.
Right. So I think lifespan analysis of what happens over, you know, we often have the issue of undiagnosing some of these patients, especially with von Willebrand's disease. And before we do that, we have to really rethink that, do we have the data to truly say that older women do not bleed regardless of factor level? So here's another interesting question. Do we know how much to expect factor activity levels to increase in carriers on oral contraceptive pills at the time of presentation? And would you decrease your threshold, that is, increase the level at which you do further testing for carrier state in a woman already on oral contraceptives?
So that's a question that comes up quite a lot. When you take patients that don't carry the hemophilia gene and you start them on low dose estrogen, so something less than 35 micrograms, studies have shown that there's no difference in the levels, whether they're on it or not. We do know in the first couple of days, the level might be at its lowest and might be the best time to check it. We are learning, at least at our institution, that somebody comes in with active bleeding, particularly heavy bleeding that leads to anemia. That is not the ideal time. We have seen levels go up into sub 100 or above 100. And then when we come to a sort of a steady health state, it drops closer to 40%. And so I think it's important to check this over time serially. I don't think low dose estrogen, the stuff that I use, like low estrogen, low overall Levora, I don't think that statistically increases the levels. It doesn't do anything to the factor IX level. We do know that. It's something to consider. And then I think doing serial sampling, particularly at different times of the cycle, is important. But I think it's important, you know, Peter says this a lot in his talks. We don't need to focus, and what I don't want to do is take people off of a birth control pill that's working just to test them. We'll continue to test them over time and manage them. And I don't feel like it makes any sense to stop it. It is reasonable to check it during the placebo week if you feel like that's reasonable. But I haven't seen any studies to show that there's definitely an increase in the levels. I think it'll be another great study idea. So everybody's pitching good study ideas. So feel free to write these down and do these. I'm not going to be able to take on all this.
Get the idea box going. So here are two questions which are kind of similar about the same issue of using combination therapy. So do you use DDAVP for menorrhagia control when a patient is also using oral contraceptive pills? And are there concerns for thrombosis when you use both OCPs and Amicar or Lysteda?
Yeah, so we got a really sharp audience with good questions. So these aren't, you guys aren't you're giving some good questions, but these are actually very practical questions. A lot of us know that when we prescribe Amicar, either or Lysteda in the setting of a birth control or with DDAVP, we often will get a call from the pharmacist saying that they're contraindicated. We don't know what happens in patients with bleeding disorders. We know that if we did this in a patient without a bleeding disorder, that could increase their risk of blood clots. It hasn't been studied. I know that it's a relative contraindication, but I routinely will use a low dose estrogen, combined oral contraceptives, and I will use Amicar for certain settings. So typically, if they have breakthrough bleeding, I will often say, well, use your Lysteda for a day or two. I'm not going to use Lysteda on a daily use with the contraceptives. I think if they have a true bleeding disorder, I think the risk is exceedingly low. But you obviously need to get a good family history, because remember, people can co-inherit clotting disorders like factor V Leiden, which can definitely increase the risk, particularly with a estrogen containing birth control pill. So these are all important discussions, particularly about avoiding cigarette smoking, and then staying healthy. And you need to be very aware in your very obese patients. And, you know, I think one of the things we need to understand is that even though there's sort of a fixed dose on the intranasal DDAVP, if you see that there's a very high a level with 2 sprays, consider using 1 spray. And we often will do that in patients where they get an exceedingly great response, and to eliminate the chances of having really high factor VIII levels. So just think about that, particularly in the teenage patients that may only weigh 50 to 60 kilos. They may only need that 1 spray and not the 2 sprays, despite them you know, being more than 50 kilos per the box.
So there are a couple more questions, but because of lack of time, we will definitely try to answer these questions. And you know, and I just wanted to thank you. So for those of you who have asked these questions, we have them, and we will try to answer. And you will be able to review this webinar for your reference or share today's proceedings with your colleague by visiting the fwgbd.org and accessing this webinar. For those who may have questions on this material following the webinar, we encourage you to visit Ask the Expert features on our website and submit your question online. We thank all of you for your attendance and participation, and those questions you asked were great, and we will try to capture these because these are actually research ideas. I think this is a great way of basically stimulating people's brain to think about this issue in women. I don't think anybody has even asked about the issue of using clotting factor concentrates, especially the newer ones, the non-factor concentrates, the long-acting ones. So those are issues still that needs to be addressed. So, but the time is up, so we want to keep it on time. So please feel free to ask your questions under Ask the Experts online. We thank you for your attendance and participation today, and we look forward to your return for future Foundation webinar. And thank you, Robert, for this excellent talk. Thank you.
Thank you, Roshni.